type 1 diabetes. In the initial 1 to 2 years, now at this time we discussed this, that when the when the clinical features of type 1 diabetes become obvious, at that time the 90% of the beta cells are destroyed, right? We did this, and slowly the disease starts to progress. Here also, initially, once you diagnose a patient as having type 1 diabetes, even then for the initial 1 to 2 years, exogenous insulin requirement is less because of the ongoing, there is some small amount of insulin secretion. About 10% of the beta cells are still secreting insulin. So at that time, we don't need that much of insulin. We need just less amount of insulin is needed for this patient. But then when the whatever residual beta cell reserve is exhausted, then the insulin requirements increase dramatically. Okay? Although beta cell destruction is a prolonged process, the transition from impaired glucose tolerance to overt diabetes may be abrupt. We did this, that beta cell destruction is prolonged, occurs over a period of many years, but the transition to getting the symptoms of diabetes or the hyperglycemia, that occurs in an abrupt way, okay? And is often brought about by an event. Sometimes there is infection or any other thing in which insulin requirement or any stress in which insulin requirements increase. At that time, the patient comes into full-blown type 1 diabetes. The classical triad: polyuria, polydipsia, and polyphagia. When severe, there is diabetic ketoacidosis. Now, since insulin is a major anabolic hormone, deficiency results in a catabolic state that affects glucose, fat, and protein metabolism. We discussed that insulin is the most potent anabolic hormone known. It causes glycogen synthesis, lipid synthesis, fat synthesis. When this hormone is not there, it results in a catabolic state that affects glucose, fat, and protein metabolism. These are the clinical features, classical cardinal symptoms of diabetes: polyuria, polydipsia, polyphagia. Now, how these three occurs? Why do you get all this? So, hyperglycemia exceeds the renal threshold for reabsorption. When the hyperglycemia occurs, that large amount of glucose has to be reabsorbed from the renal tubules. When the reabsorption, there's a large amount of glucose, there is severe hyperglycemia, the renal threshold for glucose reabsorption cannot occur, and glucose starts being excreted in the urine. When glucose starts being secreted in the urine, it carries the water along with it, and there is an osmotic diuresis, and this causes the polyuria, right? Loss of water, loss of electrolytes, right? Now, due to the polyuria, loss of water, and already there is hyperosmolarity due to glucose. Again, there is loss of water, so more hyperosmolarity in the body. So it causes increased levels of glucose in the blood, and due to hyperosmolarity of the blood. So what happens? The glucose starts coming out. The water starts coming out from the cells. Water starts coming out of the cells. There is intracellular dehydration. Intracellular dehydration causes triggering of the osmoreceptors and the thirst centers of the brain, and this causes polydipsia. Right? Now, due to insulin deficiency, there is catabolism of proteins and fats, which causes a negative energy balance, and it leads to increased appetite and polyphagia. So, why we have polyuria, polydipsia, polyphagia? These are the mechanisms behind all that. The combination of polyphagia and weight loss is paradoxical and should always raise the suspicion of diabetes. Polyphagia, patient feels hungry, but the patient is losing weight, which is a paradoxical thing. And this should always raise the suspicion of diabetes. Two conditions in which we will discuss the other condition subsequently. Hypothyroidism. In that also there is polyphagia and there is weight loss. In diabetes mellitus also there is polyphagia and there is weight loss. Okay, patient is eating more, but the patient is losing weight. These are the symptoms of diabetes. Patient is always tired, frequent urination, always hungry, sexual problems, sudden weight loss, wounds which are not healing, blurry vision, always thirsty, numb or tingling hands or feet, vaginal infection. Clinical features of type 2 diabetes mellitus. Type 2 is usually present in older obese patients. So nowadays, We discussed this before that because of the sedentary lifestyle, poor eating habits, fast foods, junk foods, this type of type 2 diabetes is also seen in children and adolescents. The diagnosis is mostly made on routine blood testing in asymptomatic patients. Many times, the patients of type 2 diabetes mellitus come just with vague symptoms to the doctor. Doctor साहब अब मुझे कमजोरी हो रही है, feeling fatigue, weight loss, or very common thing is patient may come with a small finger may toe may some infection हो गया, some small infection which are not healing. So this is a very common symptom of diabetes. So as such, you don't find out, but and sometimes they just come to you with weight loss, fatigue, tiredness, breathlessness, this type of things, and it's there. And in Pakistan, especially in the US, even in Pakistan, it's diabetes is very endemic. So we suggest that all patients, all people over 40-45 years of age, especially if they have a family history of diabetes, should get their blood glucose tested. Again, many times the diagnosis is made on routine blood testing. Nowadays, patient goes to the doctor for any reason. Most of the time, the doctor does a glucose test. Now, in this type of diabetes, type 2, the patient does secrete some insulin, so unrestricted hepatic fatty acid oxidation is inhibited and ketone bodies do not form. In type 1 diabetes mellitus, what happens? There is no insulin, so fat starts getting utilized for energy. Glucose cannot be utilized for energy, fat starts getting utilized for energy. When fat is utilized for energy, ketone bodies are produced, and that is the ketosis. In type 2 diabetes, there is some insulin present in the body, so unrestricted hepatic fatty acid oxidation is not there, and most of the time ketone bodies do not form. Now, acute complications of diabetes, diabetic ketoacidosis, it is a severe complication of type 1 diabetes mellitus. Rarely it can occur in type 2, most of the time it does not. Then hyperosmolar hyperosmotic syndrome. This in your book they have written the name of hyperosmolar hyperosmotic syndrome. What we used to study is hyperosmolar non-ketotic state or hyperosmolar non-ketotic coma. Okay? So here it is hyperosmolarity and non-ketotic. This is a severe complication of type 2 diabetes mellitus and hypoglycemia. Hypoglycemia is a very common complication of both the types of diabetes. Diabetic ketoacidosis, there is a serious complication mostly of type 1 diabetes mellitus. There is marked insulin deficiency. Most common precipitating factor is failure to take insulin, also stress and certain drugs. Type 1 diabetics, they are taking the insulin, someday they may forget to take the insulin, or the insulin requirement is increased in case of stress, in case of some infection, some drugs. They require more insulin, they are taking the usual dose. So they may develop diabetic ketoacidosis, or they may forget to take their dose, so they can develop it. The release of epinephrine causes increased glucagon secretion. There is decreased peripheral utilization of glucose with increased gluconeogenesis, severely exacerbating the hyperglycemia. Now, the glucose is not there. Glucose is not entering into the cells to form glycogen. Glycogen, the body needs glucose, so the glucose is formed by gluconeogenesis. So more glucose, already there's hyperglycemia and the body as a response is making more glucose, so there is exacerbation of the hyperglycemia. The plasma glucose levels may be in the range of 250 to 600 milligram per day. Hyperglycemia causes the osmotic diuresis and dehydration characteristic of the ketoacidotic state. The three keto acids which are produced, beta hydroxybutyric acid, acetoacetic acid, and acetone. There are three ketone bodies which are produced in this case. Okay? Insulin deficiency stimulates lipoprotein lipase, leading to breakdown of fat stores and increased levels of free fatty acids. Because insulin is not there, lipoprotein lipase is an enzyme which is activated, which causes the breakdown of fats. This fat breakdown causes the formation of free fatty acids, and so increased free fatty acids in the blood. In the liver, the free fatty acids are esterified to fatty acyl coenzyme A, which produces ketone bodies. In type 1 diabetes, insulin is not there, because of which, in diabetic ketoacidosis, insulin is not there, because of which glucose is not utilized, cannot be utilized for energy, so fats are utilized for energy. Okay? Fats are utilized. Free fatty acids, lipoprotein lipase, acts on the fats to reduce free fatty acids. Free fatty acids are converted to fatty acyl CoA, and that is converted to the ketone bodies. Acetoacetic acid, beta hydroxybutyric acid, and acetone. When this is ketonemia, right? And if the excess ketones in the blood, so the ketones start being excreted in the urine. So we get ketonemia and ketonuria, right? If the urinary excretion of ketones is compromised by dehydration, supposing the patient, because we discussed the dehydration does occur in this. So if there is dehydration, so less ketones are being excreted. So when the less ketones are being excreted, these ketones accumulate in the body, and because they are acidic in nature, they cause metabolic ketoacidosis. If you remember your ABGs, when we discussed the ABGs, the one of the very common causes, one of the very important causes of high anion gap metabolic acidosis was diabetic ketoacidosis. Okay, so ketone bodies are produced. These three ketone bodies, two have been written in your book: acetoacetic acid and beta hydroxybutyric acid. These are the ketone bodies which are measured in your blood. Acetone is a volatile substance that is excreted in the breath. So the typical Kussmaul's breathing, because there is a typical smell of diabetic ketoacidosis, fruity smell comes out from their breath, and this is because of the acetone. So acetone cannot be measured in the blood. Acetone can be measured by a breath test. Okay? Clinical manifestations of DKA: there is fatigue, nausea, vomiting, severe abdominal pain. The characteristic fruity or odor is because of the acetone. Deep labored breathing, because the body is trying to remove the excess of acid. Loss of, we are trying to remove the carbon dioxide, right? And because of this, there is deep labored breathing, and this is called Kussmaul's breathing. This is typical of ketoacidosis. Persistence of the ketotic state eventually leads to depression and cerebral consciousness, and coma. Reversal of ketoacidosis requires administration of insulin, correction of metabolic acidosis, treatment of the underlying precipitating factors, example, infection. Okay, so you have to give the patient insulin, you have to correct the metabolic acidosis, and you have to some underlying factor, some infection, something is there, you have to treat that. Now we come to hyperosmolar hyperosmotic syndrome. This is developed in or hyperosmolar non-ketotic state, which we call it. Type 2 diabetes can develop this. Insulin is present. Now here, insulin, there is some insulin which is present in the body. This type 2 diabetic patient is secreting some insulin. Because of this, unrestricted hepatic fatty acid oxidation is not there. Some glucose is being utilized for energy. So all of the energy is not taken from the fat. So because of that, unrestricted hepatic fatty acid oxidation is not there. Because of this, ketone bodies do not form. There is sustained osmotic diuresis leading to severe dehydration. We discussed this when the lot of glucose is secreted in the urine. It takes up the water along with it, and so there is severe dehydration. Especially in those patients who cannot drink enough water to compensate for the urinary loss from chronic hyperglycemia. Which people are they? They are the elderly patient who are disabled by a stroke or an infection. Old patient lying on the bed cannot ask for or does not feel so much of thirst and cannot take up that much water. So these people then develop a severe dehydration. The absence of ketoacidosis and its symptoms, nausea, vomiting, and Kussmaul breathing, delays the seeking of medical attention. Ketoacidosis has got these typical features: Kussmaul's breathing, nausea, vomiting. Here there is nothing. So there is the patient does not realize, or the attendants do not realize that the patient is going in severe dehydration until coma occurs. And in this case, the hyperglycemia is usually more severe, about 600 to 1200 milligram per year. So hyperosmolar coma is more severe hyperglycemia as compared to DKA. DKA was 250 to 600 milligram per year, whereas in case of hyperosmolar hyperosmotic syndrome, the hyperglycemia is 600 to 1200 milligram per year. Now, hypoglycemia, very common cause of very common acute complication of diabetes in both of the type of diabetes. Usually, as a result, having missed a meal, patient is not hungry, didn't eat food, took the usual dose of insulin or took the usual insulin tablet, or some excessive physical exertion occurred, increased insulin administration during the phase of dose finding for anti-diabetic agents. We are looking for the dose, and at that time, you can have a little larger dose than necessary, and the patient can go in hypoglycemia. Also, this is seen in case of can be sometimes. This is seen the patient may have use double the insulin dose. Forgets कि मैंने insulin लिया था या नहीं लिया था, चलो ले लेते हैं. So the patient can have double the insulin dose. So in this case, what is important is that we'll discuss this. Signs and symptoms: dizziness, confusion, sweating, palpitations, tachycardia, loss of consciousness. So we discussed about C-peptide last time, if you remember. In this case, hypoglycemia, in patients who come to the hospital with hypoglycemia, you can measure their insulin and the C-peptide levels also. So why? Because it gives us a clue. If the patient is taking exogenous insulin injection from outside, the C-peptide level, the insulin levels of that patient will be raised, but the C-peptide levels will not be raised. Because the injectable insulin, the exogenous insulin, there is no C-peptide in the body, right? So if you measure the C-peptide, you find out if there is patient has taken exogenous insulin, or if the patient has got an insulinoma, for example, tumor of the pancreatic cells producing a large amount of insulin, then the C-peptide will be high. So to differentiate between these two, that whether the patient is producing that much insulin or the patient has exogenously administered the insulin, you can measure the C-peptide levels. Yeah, because here sometimes this is used in case of for suicidal purposes or for murder purposes, homicidal purposes. Also, people do that they give excessive insulin to the patient, and the patient goes in hypoglycemia and dies. So at that time, you have, when you do the C-peptide, you find out whether it is due to exogenous insulin or whether it is due to endogenous insulin. Okay? Reversal of hypoglycemia through oral or IV glucose prevents the onset of permanent neurological damage. Now, this patient, when the patient is in hypoglycemia, the patient will be maybe loss of unconscious. You take the patient to the hospital and on a stretcher. There, large doses of glucose are given to the patient, and the patient, I have seen this, patient goes home walking within hours. So this is a very preventable and very easy way of improving the patient's outcome. Now, the chronic complications of diabetes, there are two types of chronic complications. There are macrovascular diseases and there are microvascular diseases. Macrovascular diseases means the lesions involving the large and the medium-sized arteries, and because of damage to the large and medium-sized arteries, there is accelerated atherosclerosis, and because of this, increased risk of myocardial infarction, stroke, and peripheral gangrene. Microvascular disease, there is capillary dysfunction. So in macrovascular, it is the arteries, large, small, and medium arteries. In large and medium, sorry. In microvascular disease, there are the capillaries which are damaged, causing diabetic retinopathy, nephropathy, and neuropathy. The pathogenesis of the long-term complications of diabetes is multifactorial, although persistent hyperglycemia seems to be the key mediator. It is mainly the persistent hyperglycemia which causes this. Assessment of glycemic control is based on the percentage of glycated hemoglobin. We discussed this yesterday, the day before yesterday, about glycated hemoglobin. Glucose, we discussed this, glucose attaches to the RBC. As the life of the cycle of the RBC is 120 days, we get the previous record of the patient of the last 3 to 4 months. And it is recommended that HbA1c should be maintained below 7% in diabetic patients. For normal patients, it is 5.7 glucose HbA1c, but for a diabetic patient, you should maintain the glucose below 7. Hyperglycemia is not the only factor responsible for the long-term complications of diabetes. Many of these patients, because along with the hyperglycemia, they have insulin resistance, and comorbidities like obesity also are there. Now, for the pathogenesis of the complications, there are 4 distinct metabolic pathways, and which cause the harmful effects of the hyperglycemia. And there is, in each of the proposed mechanisms, there is increased glucose flux through various intracellular metabolic pathways, and it causes the formation of harmful precursors that contribute to end organ damage. Because of the hyperglycemia, certain pathways of the blood cells are destroyed, and it causes harmful precursors are produced, and they cause end organ damage. What are the 4 things which can be there? The formation of advanced glycation end products, which are called AGEs, activation of protein kinase C, oxidative stress and disturbances in the polyol pathways, hexosamine pathways, and generation of fructose 6-phosphate. Formation of AGEs. AGEs are formed as a result of non-enzymatic reactions between intracellular glucose-derived dicarbonyl precursors with the amino groups of both intracellular and extracellular proteins. In short, the glucose, when HbA1c, we discussed that glucose attaches to the RBC. In this case, glucose attaches to the amino groups, to the proteins. Okay? And both the intracellular as well as the extracellular. The natural rate of AGE formation is greatly accelerated in the presence of hyperglycemia. Those people who do not have diabetes, even then, small amount of glucose is attached to the proteins. AGEs are produced, but patients who are hyperglycemic, the rate of AGE formation is greatly increased. AGE binds to specific receptors, which is called RAGE, and which is expressed on the inflammatory cells, endothelium, and vascular smooth muscle. And because of this AGE attaching to the AGE receptor, there is release of cytokines and growth factors, including the transforming growth factor beta, TGF-beta, vascular endothelial growth factor, VEGF, and implicated in diabetic retinopathy. These 2 factors, they cause diabetic retinopathy. Then there can be generation of reactive oxygen species. There can be increased procoagulant activity. Increased coagulation causes thrombosis, proliferation of vascular muscle cells, and extracellular matrix. Activation of protein kinase C. Intracellular hyperglycemia stimulates the synthesis of diacylglycerol from glycolytic intermediates and causes activation of protein kinase C. PKC activation causes the production of VEGF, again, TGF-beta, and there is another one which is procoagulant protein plasminogen activator inhibitor 1. And all of these factors are implicated in the neovascularization characterizing diabetic retinopathy. All these factors which are produced, they cause diabetic retinopathy. Then oxidative stress and disturbance in the polyol pathways. In some tissues that do not require insulin for glucose transport, that is nerves, lenses, kidneys, and blood vessels, persistent extracellular hyperglycemia leads to increase in intracellular glucose. Because insulin is not needed, there is hyperglycemia, so this glucose enters into the cells, and there is intracellular hyperglycemia. Now this glucose, it is metabolized to sorbitol, which is a polyol, and fructose using NADPH. NADPH is also required to produce glutathione, which is an antioxidant. When all the NADPH is utilized by the glucose to produce sorbitol, there is no NADPH left to produce glutathione, which is an antioxidant. So antioxidant is not there. So this causes, there is more susceptibility to oxidative stress. Sorbitol accumulation in the lens leads to cataract formation. Hexosamine pathways and generation of fructose 6-phosphate. Hyperglycemia causes increased intracellular levels of fructose 6-phosphate, which causes increased glycosylation of proteins, leading to generation of excess proteoglycan. This causes increased TGF-beta or PAI1, which is exacerbates the end organ damage. So all of these pathways, mainly these 3, VEGF, TGF-beta, and PAI1, these are the 3 things which are mostly produced, and they cause the end organ damage. Clinical features of the long-term effects of diabetes. So it is mainly the long-term effects of diabetes that are more causing more morbidity and mortality as compared to the acute complications. You find very few people, hypoglycemia, yes, it is common. But hyperglycemia, diabetic ketoacidosis, and hyperosmolar coma and all, Nowadays, with the better medical practices, people are more aware, so that doesn't happen so frequently. But the chronic complications of diabetes, the long-term effects are the main ones which cause the morbidity and the mortality. The severity of chronic complications depends on the degree and the duration of hyperglycemia. Macrovascular complications, there can be myocardial infarction, renal vascular insufficiency, and cerebrovascular accident. Most common cause of mortality in long-standing diabetes. Very common, patients with myocardial infarction, they have strokes, they have peripheral gangrene. Okay? And many of these people, diabetics, you must have noticed, I'm sure that many of you will have parents or grandparents having diabetes. So many of these people with diabetics, they have associated factors also along with the diabetes, which are hypertension. Most of them diabetes have hypertension, and this aggravates the endothelial dysfunction and the atherosclerosis also. Then many of these patients have dyslipidemia, the lipid levels are abnormal, increased triglycerides, LDL, reduced HDL, and all of these increase the formation of the atherosclerotic plaques. And also insulin resistance is believed to contribute to the diabetic dyslipidemia. Patients have got insulin resistance and this causes the dyslipidemia. Diabetics also have increased PAI1, which is an inhibitor of fibrinolysis, so acts as a procoagulant in the formation of atherosclerotic plaques. Atherosclerosis occurs, and over there when the procoagulants occur, there is coagulation, thrombosis, and it can cause the MI and the stroke. Microvascular changes, diabetic microangiopathy, one of the most consistent morphological features is diffuse thickening of the basement membrane. The capillaries, they are affecting the capillaries now. There is diffuse thickening of the basement membranes of the capillaries, and they cause the microvascular changes. And the three most important microvascular complications of diabetes are diabetic nephropathy, diabetic retinopathy, and diabetic neuropathy. Diabetic nephropathy is the leading cause of end-stage renal disease, ESRD, in the US. Type 1 diabetics also develop renal problems. About 80 to 90% of type 1 diabetics will develop nephropathy. About 20 to 30, 40% of type 2 diabetics will also develop diabetic nephropathy. Okay, renal disease is caused in both types of diabetes. But the progression to end-stage renal disease is more seen in case of type 1 diabetics as compared to type 2 diabetics. Okay. Now, the earliest manifestation, how do you find out that the patient has got diabetic renal damage is you test the patient for urine microalbumin. Okay. Urine microalbumin is basically not a small type, micro means small, albumin, small type of albumin. It is actually a misnomer. It is not a small type of albumin, but it is the small amount of albumin in the urine, which is called microalbuminuria. Okay? So how much amount of urine? Less than 30 milligram per day is considered normal. So the patients having more than 30 milligram per day urine excreted, albumin excreted in the urine over the period of 24 hours is called microalbuminuria. So that when patient has got microalbuminuria, then you know that this patient is now having renal problems which may be due to the diabetes. Okay? Microalbuminuria is a marker for greatly increased cardiovascular morbidity and mortality in both types of diabetes. Once the patient has microalbuminuria, then you should definitely screen the patient for any of the cardiovascular morbidity and mortality also. Okay? And about 80% of type 1 diabetics and 20 to 40% of type 2 diabetics will develop overt nephropathy with macroalbuminuria. Now, these patients, when they start secreting more than 300 milligram per day, which is called macroalbuminuria. And this is most of them of type 1 diabetics, and quite a lot of type 2 diabetics will develop macroalbuminuria. That means a large amount of albumin being secreted in the urine, more than 300 milligram per day. And many of these patients will develop end-stage renal disease requiring dialysis or renal transplantation. Visual impairment, most diabetics develop some form of diabetic retinopathy. The fundamental lesion is neovascularization due to increased VEGF in the retina. Diabetic retinopathy consists of a constellation of changes that are considered to be diagnostic of the disease. These constellation of changes, maybe they have been discussed in endocrinology with you, or when you do go for your eye, they can show you the diabetic retinopathy characteristic changes. Diabetics also have an increased risk of developing glaucoma and cataract, and sometimes even total blindness can occur. This is a diabetic foot ulcer. Now, small amount of infection, patient chalte chalte kuch lag gaya, keel lag gayi, anything can hurt your foot. And diabetic patients, these things don't heal so easily. And after that, this is a diabetic foot ulcer over here, shown over here. And see, this is still very infected. This yellow area shows that it is still highly infected. And slowly and gradually, this can lead even to gangrene and amputation of the foot. Similarly, this is the retina, diabetic retinopathy. There are microaneurysms, exudates, abnormal blood vessels, hemorrhage. There are characteristic typical changes seen in diabetic retinopathy. Diabetic neuropathy. A variety of clinical syndromes can occur affecting the central nervous system, peripheral nervous system, or the autonomic nervous system. Any of the nervous systems can be damaged due to diabetes. Most frequent finding is distal symmetric polyneuropathy of the lower extremities that affects both motor and sensory function. Most commonly in the foot, diabetic foot, which we call it, the patient has sensory loss, motor loss in both the legs. Now, later, there can be upper extremity can also be involved, and this is called a glove and stocking pattern of polyneuropathy. Autonomic neuropathy may cause disturbed bowel and bladder function. Sometimes sexual impotence can also occur. Diabetic mononeuropathy, when one nerve is damaged due to diabetes, may manifest as sudden foot drop, wrist drop, or isolated cranial nerve palsy. Also, susceptibility to infections. Diabetics may develop infections of the skin. Very common that a patient comes to you, does not know that he is diabetic, and he has got a small infection in his finger, which is not healing. Or the patient may know that he is diabetic, even then the infections are not healing. And they are susceptible to developing tuberculosis, pneumonia, pyelonephritis. A trivial infection in a toe of a patient with diabetic neuropathy may be the first event in a long line of complications. Now the vessels are also destroyed. In the blood vessels of supporting the foot, the patient has got diabetic neuropathy and the macrovascular changes also. So the patient doesn't have any sensation, there is loss of motor function, there is loss of sensory function, there is lack of blood supply to the foot, and small infection occurring in the foot, the patient can have gangrene, bacteremia, pneumonia, and patient can ultimately die because of it. This is a diabetic foot. This is gangrene of the foot, and this patient must be needing an amputation of the foot or maybe even the leg. These are the complications. Macrovascular complications, coronary artery and cerebral vascular disease, microvascular complications, retinopathy, nephropathy, and neuropathy. Now, one thing which has not been discussed, which is not there in your book, and I wanted to discuss this with you, is the metabolic syndrome. What is metabolic syndrome basically? I don't know if you have heard of this. In this disease, abdominal obesity and insulin resistance are accompanied by a constellation of risk factors for cardiovascular disease like abnormal lipid profile. There are certain criteria for this disease, and if the patient meets, there are 5 criteria basically. If the patient has any of the 3 criteria of this disease, the patient is said to have metabolic syndrome. And these patients are more likely to develop abnormal lipid profile. Abnormal lipid profile, it is part of this thing, but they have more chance of risk of developing cardiovascular disease. How do you diagnose metabolic syndrome? At least 3 of these 5 criteria must be met. 5 criteria. First is fasting glucose to at least 110 milligram per dl. Okay, fasting glucose greater than 110 milligram per dl. Triglycerides greater than 150 milligram per dl, equal to or greater than 150 milligram per dl. Blood pressure at least 130 by 85 millimeters mercury. High density lipoprotein cholesterol, which is a good cholesterol, if it is below 50 in women and below 40 in men. Central obesity, abdominal waist circumference greater than 35 inches in women and abdominal waist circumference greater than 40 inches in men. These are the 5 criteria for diagnosing metabolic syndrome, and if any of the 3 criteria are met, the patient is considered to have metabolic syndrome and more likely of developing of cardiovascular disease. And they can develop diabetes, they can develop cardiovascular disease, and they benefit from weight reduction, dietary modifications, and change in lifestyle. ठीक है, this is all about for us to